Now 8:02, 8:03. It's David Rawson, founder and president of the Canadian Academy of Clinical Sleep Disorders Disciplines. Welcome everyone to our third edition of Wednesday webinars. We're very pleased to have with us tonight from Las Vegas, Dr. Dennis Bailey, who was with us in Toronto in 2019 and gave two excellent presentations. And there was a great demand to have him back. A thing called COVID got in our way, and of course we weren't able to have an in-person meeting this year, which would be held about now. And Dennis stepped up and asked if he could contribute, and of course we accepted. So we are going to turn it over to Dennis very quickly. The rules are quite simple. Mute your own microphone so that there's no background noise interfering with the speaker and others' ability to hear. It'll be a standard 45 to 50-minute lecture, at which time we're going to open it to questions and answers. I know Dr. Bailey is very open to expanding your knowledge by answering the questions that may have popped up. You know him well if you've been reading our announcements. His bio sketch is too long for me to read, but this is a very sincere man who really, really wants to help us as a dental profession treat our patients to a higher level, which is what the Academy is all about, and also to build a big tent to include our medical partners and our sleep technologists and our labs and our vendors all under one tent so that we can all work more effectively and bring a higher level of healthcare to our citizenry. So make sure you're muted, unmute when it's question and answer period. This will be recorded, and hopefully we'll get this on the website for those of you who couldn't make it. So without any further ado, I turn it over to Dr. Dennis Bailey from Las Vegas, Nevada. Thank you, Dennis, for joining us tonight.
David, thank you very much. It's good to see you again. I regale in the fact that when we met almost a year and a month ago, we had so much in common in our paths to where we are now. So one of the things that is very important to me is the importance of the nasal airway. Not only for sleep disordered breathing, but just for life itself. And so what I'm proposing here is that the nose knows, but there's an importance of the nasal airway that we need to really be aware of. So my introduction, we're going to look at function and physiology of the nasal airway. We're going to look at anatomy of it. We're going to determine how to do an evaluation, cursory evaluation, more of a screening, from our perspective as dentists. Many of you understand that as dentists, our perspective of certain things is different than our physician colleagues. Not that that's bad, it's just that our training and some of our limitations prevent us from doing a more in-depth evaluation. We'll look at management of nasal airway compromise and ways to improve nasal breathing, both daytime and nighttime. We'll look at importance related to management options as they may exist. And we'll talk a little bit about interacting with our physician colleagues, because that's pretty important. Part of this is based upon what we see now as the future or the pending future of dental sleep medicine. For the longest time, I've not been a proponent of the term dental sleep medicine, because I felt it didn't really define what we did. The breadth of it wasn't there. But there's been some new information that's come about. I'll cite that for you shortly, that looks at dental sleep medicine in a new light and expands upon the definitions that define what our role is as it relates to this whole field as dentists. And evaluation and understanding the nasal airway is part of it. And I'll expand on that whole definition, that whole process as we go along. Dental sleep medicine really now goes beyond sleep breathing disorders and oral appliance therapy. That's something where we've kind of been, I'll say, partitioned into or kind of boxed into. We need to get out of that box and think a little differently as to how we can help these patients. The practice of dental sleep medicine now involves the craniofacial structures, and this includes the nasal cavity and the upper airway. So the new definition, or one that has been proposed, is that dental sleep medicine is a discipline concerned with the study of the oral and maxillofacial causes and consequences of sleep-related problems. It doesn't say sleep disordered breathing. It doesn't say oral appliance therapy. But this definition, which was published 4 years ago in the Journal of Oral Rehabilitation, is really quite profound and I think of great interest. So dental sleep medicine, based upon the citations that I have down below, indicate that the dental management of OSA is still there. Our role, of course, is in oral appliance therapy, but we also have to expand that role beyond oral appliance therapy when there are other recognizable sleep disorders. Assess and manage sleep bruxism. All of us as dentists have been trained in how to deal with bruxism, but when we look at sleep bruxism, it takes on a whole new realm. Association of sleep bruxism and sleep-related disorders, not just sleep-related breathing disorders, because it can impact a lot of things. It can be related to restless leg syndrome, to periodic limb movement, and it can be related to insomnia. And there is a bidirectional relationship. I did a lecture about 2 weeks ago on this very thing, and I actually expanded it to a three-legged stool because there are three legs to it. But let me explain what the slide says. Bidirectional relationship between orofacial pain and sleep disorders. But the third leg of that stool is mood disorders. And mood disorders play into disruption of sleep, not necessarily related to sleep-related breathing disorders. Medicine during sleep. This is a synopsis of an article, more of a letter to the editor, that was published in Sleep earlier this year. So medicine during sleep refers to the fact that it's not the same as sleep medicine as we currently view it. Medical and health concerns during sleep may actually be different when compared to the awake state. This applies to nasal breathing. Nasal breathing is not the same at night as it is during the day, and we'll look at that in more detail. Blood pressure is an example. It's elevated during sleep, is more closely associated with fatal and non-fatal cardiac events during the sleep period, but not necessarily during the daytime hours. And the question is, do non-specific diseases occur only during sleep? Well, think about it. One that is very profound is gastroesophageal reflux disease, or GERD. That is more prevalent between 10 p.m. and 2 a.m. than it is during the day, for the most part. Mouth breathing in the nasal airway. This is where the focus is going to go now. What I was talking about before was designed to be sort of a lead-in to how it all comes together in terms of what we're doing within dental sleep medicine. So mouth breathing can lead to changes that further limit the ability to nose breathe. These are craniofacial changes. These are things that occur to the craniofacial structures that may impact the nasal airway anatomically. Most is predicated on enlarged adenoids, which is true, which limits nasal breathing, cuts down on air exchange through the nose. The tonsils can also be involved, but this is the start of a sleep breathing disorder, and then, of course, leads to OSA. In between these two is snoring and upper airway resistance syndrome. And upper airway resistance syndrome is taking on a new meaning these days, because what it's saying is that this may be something more prevalent in the younger age group, which is a group of people who are oftentimes ignored when it comes to sleep breathing disorders. Certain growth developmental considerations need to be made. We need to start looking at children and adolescents. In other words, we need to start looking at our patients at an earlier age. We need to observe their growth and development. One of the shortfalls in my dental education was I graduated with a very minimal amount of information or knowledge in growth and development. And it took me the better part of half of my career, better part of 20 years, to really get a good handle on growth and development and understand what it was all about. But from Dempsey in the journal Chest almost 20 years ago, he looked at this and indicated that obesity and craniofacial abnormalities account for 2/3 of the variations in OSA measured by the HI. That's amazing. Obesity and craniofacial abnormalities is 2/3 of what we're dealing with. And as you all know, obesity is really a problem that's on the rise to a large degree. Well, what is the impact of mouth breathing? We look at the cartoon here on the right-hand side of the screen, and it shows you the normal amount of, or the normal pattern or pathway of facial growth. And on the other side is where there's airway restriction. And you can see how the face does not develop fully, how there's more of a long face type syndrome. This is predicated a lot on adenoidal facies, or a condition referred to as adenoidal facies. It's based on previous studies from the 70s that went into the 90s. And a lot of the authors were people like Harvold and Woodside from Toronto and Linda Aronson from USC. And what they did, which is something that we probably couldn't get away with today, is they took and they plugged up the noses of rhesus monkeys. And they watched how the impact, or how it impacted their craniofacial development. This set the stage for our understanding of the cartoon on the right in terms of how nasal breathing can lead to a pathway on the left and mouth breathing leads to a pathway on the right. Well, enlarged adenoids, and the adenoid resides up in this area here, up in the nasopharyngeal area or nasopharynx, and it's very close to the eustachian tube. You see here is the nasal cavity. We have to understand that the nasal cavity runs from here to here. We'll get into that in a little bit more detail. This portion right in here is the nasopharyngeal airway. So when the adenoid is enlarged, it really chokes off airflow going through this area. So if the patient experiences a lack of adequate airflow or adequate oxygenation, the typical pattern is now to become what we term obligate mouth breather. So here we see on cephalometrics, we see average size adenoids. Look at the opening here of the nasopharynx. We look over here and we can see how that nasopharynx has more or less been minimized by virtue of the adenoid that's been enlarged. We can also deal with tonsillar hypertrophy. Here we see very enlarged tonsils, and we see crypts in those tonsils, which is indicative of past experiences of airway problems or infection rather. Here we see a cephalometric X-ray, and this is meant to show one thing in particular, and that is these are the tonsils as we see them clinically, and we look at them across or laterally across how they affect the airway. What we don't really realize is look how far down that tonsillar tissue goes into the hypopharynx here. And that tonsillar mass, which is going way down in here, is really closing up the oropharyngeal and the hypopharyngeal airway. Grading of tonsils is very important. We need to understand the ENT definition of grading. This is a grading of tonsils. It's out of the ENT literature. And you can see that it goes from 1 to 4+. And here we see 0 where they're not visible. Doesn't mean they've been removed, just means they're not present. Barely visible to a quarter of the way, half the way. And then of course, what's called kissing tonsils, where they're massively enlarged. So, I don't know what happened there. Okay. I'll have to go back there. I don't know what happened.
Zoom 5.0. Well, we're not going to download anything now, Dennis.
Hang on.
That's the nice thing about you being in control. I can't help you, I don't think. Looks like you got kicked out of your own presentation.
Somehow, yes. So let's get back to the slide where I was. Here we go. There we go. So this is a area defined back in the 1800s called Walder's ring. And it's a group of lymphoidal tissue that makes up this area in the upper airway.
Dennis, can I interrupt? I'm only seeing your desktop.
Oh, really?
I can see nasal airway highlighted, but your slides did not come back. And it's not blue, it's grayed out as if it's not. There we go. Okay, got it now.
Okay, good. I'm sorry.
That's okay.
Walder's ring rather, is a group of lymphoidal tissue. And it's basically a circular area that involves this area here. You got to think of things as being bilateral. And so here we see the adenoid, which is a unilateral mass, and the lingual tonsil, which is a unilateral area, which is at the base of the tongue. On either side, more posteriorly, we see the palatine tonsils, which are your typical tonsils. And then there's what's called a tubal tonsil, which exists in the nasopharynx on either side of the adenoid, slightly more inferior. So this ring is an important aspect of all of the lymphoidal tissue that can exist in the upper airway, mainly in the nasopharyngeal airway. But it is the body's first line of defense. And so this Walder's ring is really, in some cases, can be problematic for airway and for breathing. Well, there is a relationship of adenoids to the ear. And that is by virtue of the eustachian tube, which is here. Now remember, the adenoid would exist in this area here, very close to eustachian tube. And so many times patients will have what is called eustachian tube dysfunction. And the first signs can actually be sleep bruxism, it can be ear infections, clogged ears, hearing loss, even learning issues. Now let's take a look here. One of the things that's important about understanding the eustachian tube is here we see the eustachian tube here. And you'll notice that it's almost horizontal. It's almost a straight line from the inner ear into the nasopharynx. As the individual grows and matures, there's an increase in lower facial height that occurs. And that lower facial height now allows the eustachian tube to have more of a downward path. So it can open up by virtue of gravity as opposed to here. And this is why so many kids experience this clogged ear feeling as opposed to adults, except in flying, of course, but they experience this. Now you say, why sleep bruxism? Well, it's an interesting model, and it was proposed in the osteopathic literature many years ago. And basically what they found was that when the ear is clogged, picture yourself landing in an airplane. When the ear is clogged, what do you try to do? Well, you may try to move your jaw around or swallow a bunch of times, or try to exercise your jaw. Well, what happens is that this sets up a pattern of rhythmic movement of the jaw and can lead to bruxism during sleep, trying to clear that eustachian tube or the eustachian tube dysfunction. So ear problems can be associated with nasal airway problems and with adenoidal enlargement. Well, route of respiration, this is important. The lack of ability to nose breathe and adequate nasal breathing can be first recognized as a mouth breathing habit or mouth breathing pattern. Nasal breathing is really the preferred route of respiration, and ideally mouth breathing should only occur for about 4%, approximately 4% of a 24-hour day. Daytime mouth breathing is typically a lot less than what we see at night, and many are actually poor nasal breathers at night during sleep. And there is a postural component. Lying down causes the airway to become more obstructed. There can be more nasal obstruction or nasal congestion. And so this can lead to, again, what's called obligate mouth breathing. Other considerations can be allergy, acid reflux, asthma, which can be related to acid reflux. National Jewish in Denver, Colorado published a paper 20 years ago, and they showed that the leading cause of asthma in North America was actually acid reflux. So all of these conditions can be related to it. Well, in CHEST back in 2006, they published a paper, and they said that daytime and nighttime are both mouth breathing. Daytime breathing does not equal night breathing. In other words, their point was in this paper that just because you're a mouth breather at night doesn't mean you're going to be a mouth breather during the day and vice versa. And they said that mouth breathing, particularly at night, had 100% positive predictive value for OSA. So we need to be cognizant of that because mouth breathing can oftentimes be a sign that the nasal airway is not able to function properly. Now, it can also be by obligation, only because the past history caused the patient to be a mouth breather due to nasal obstruction. But once the nasal obstruction was relieved, either through surgery, maybe allergy correction, or just outgrew it, now they just breathe through the mouth because of an habitual situation and not because there's actually a nasal airway problem. So what do we see in the mouth that could indicate that somebody is actually a nasal breather? Well, there's not a nasal breather, it's a mouth breather. There are three conditions: tongue coating, where the tongue has a pasty, straw-colored material, usually at the posterior 2/3. This midline groove, that is pathognomonic of a mouth breather. So when you see this groove, this sort of inverted V, that's a mouth breather. And then scalloping, crenations as they're called, on the side of the tongue can be indicative of it. In the otolaryngology head and neck surgery paper back about 12 years ago, they published that those people who had sleep apnea and also had crenations was a very high correlation. So we know that there's some relationship to sleep breathing disorders. Well, let's talk now specifically about the nose and the nasal airway. I refer to the nose as the portal of the airway. It's the opening for the airway. The reason is because air passing through the nose is warmed and humidified. It's the first stage of warming and humidification for the ability of the lungs to pick up oxygen. It humidifies the air to roughly about 80%. It warms it to approximately 90 degrees. And the paranasal sinuses release nitric oxide into this inspired air. Now, of course, the nose also, by virtue of ciliary columnar epithelium, filter the air. But these are the principal obligations of the nose. This is what we're doing. This warmed and humidified air, as it passes through the lungs, goes through a second stage of warming and humidification, which significantly improves uptake of oxygen out of the inspired air. The nitric oxide, which is a gas, is emitted by the paranasal sinuses. And that emission of the paranasal sinuses, I have a slide of that, basically being a vasodilator, improves the absorption of oxygen out of the inspired air. So if you've got someone who you expect or may think or you have suspicion or that you think they're at risk for being somebody who's got a problem with their nasal airway, this is a very simple subjective scale that can be used called the NOS, Nasal Obstruction Symptom Evaluation. And this is what they perceive of their nasal breathing over a month's period of time, or not much of a problem. And you can see how it's rated, and then there's a visual analog scale that they can use as well. But this is a very, very good way to determine the patient's perspective as to whether or not their nasal breathing is sufficient or not, and if something should be done or looked into further. Now, what we see when we look at the nose is only about 30% of the total volume of the nose, because we get into the nasal cavity here, which this is the nasal cavity, this is nasopharynx, okay? They're walled off, and I'll show you the walling off and what that structure is called. But this is really here is 70% of what we see here. So we have to be cognizant of the fact that we're looking at a very minimal amount when we look in the nose. Okay? So here we are looking into the nose. The nostrils, or what's really referred to as the nasal vestibule, and you can see they're different on either side. You can see that this is off to an angle, which would tell me that there is a nasal septal deviation here. And this is a little bit wider than I would like to see here. This is called the columella. We'll get into that momentarily. But this is the normal pattern of airflow through the nose. The normal pattern is for air to enter the nose, pass by the inferior turbinate and middle turbinate into the nasopharyngeal airway, into the oral pharynx, and into the hypopharynx. So physiology of the nasal airway, as I pointed out at the onset, is known as the carburetor of the body for humidification and warming, and also filters. The nasal airway also contains nitric oxide as a gas that comes from the paranasal sinuses. And it's delivered continuously into the nasal airway, into the air that's inspired through the nasal airway. Being a vasodilator, it enhances the uptake of the O2 by the blood. And another reason to nose breathe and not mouth breathe is that the blood oxygen levels will be about 10% higher with nasal breathing versus oral breathing. Here's the paranasal sinuses. Okay, we're pretty much familiar with them. They surround the nose and, of course, the maxilla and the sphenoids up in here. And these nasal sinuses emit the nitric oxide into it. It's not the only source of nitric oxide, but it's a major source for the nasal cavity. Well, we didn't know much about nitric oxide until 1998. And in 1998, these three individuals were awarded the Nobel Peace Prize for physiology and medicine for discovering the role of nitric oxide. We knew of nitric oxide, but didn't know the role of it. And they discovered it as a signaling molecule in the cardiovascular system, vis-a-vis nasal dilation. So a little bit more information on nitric oxide, because it's a very interesting substance. It is stable in very low concentrations, but can be rapidly destroyed. It's a potent vasodilator, which also has anti-inflammatory properties. It's produced mainly by white blood cells. This is other parts of the body, not in the nasal area. And interestingly, it kills bacteria, fungi, and viruses. Now, could that have been an implication in why some people who developed COVID didn't do as poorly as others, in that they were nasal breathers? You know, there's a paper out there that shows that roughly about, well, much more than 50% of those patients who were hospitalized for COVID also had comorbid sleep apnea. So we know that nitric oxide not only is a potent gas for vasodilation, but also can be very helpful in terms of its antibacterial and anti-inflammatory properties. It also has an impact on the hypoglossal motor nucleus. And so by breathing through the nose, the nitric oxide stimulates the hypoglossal motor nucleus and helps to keep the tongue base forward by stimulating. It's sort of like the Imthera device or the implantable device for hypoglossal nerve stimulation, only now we're using the body's nitric oxide. And it's an important in angiogenesis for wound healing. So when we have wounds or we have other things that are other injuries, angiogenesis can go on, cell reproduction can go on by virtue of nitric oxide production. And in diabetes, it's been found where it's uncontrolled, it can be reduced. And so this points to some of the rationale as to why so many diabetic patients have other types of maladies, such as cardiovascular disease, kidney problems, liver problems, infections, or things that can lead to circulatory problems and so forth, is related to the nitric oxide or the depletion of nitric oxide. What often happens in diabetes is they end up with a high blood sugar of it stimulating more nitric oxide, but then it's broken down very quickly, so it's not able to do the job that it's supposed to do. A few nitric oxide references. I'm not reading these to you. It's a slide I put in there with the handout so you can look some things up for yourself and do some reading on it. It's a fascinating topic to me. There's actually an entire journal on nitric oxide. I throw this in for your listening pleasure. Dreaming, is it in color or black and white? This was an interesting study that was published in 2008 I came across recently. Well, before the introduction of color television, only 15% of people dreamed in color. Today, the majority do, but a study from the University of Dundee found that 12% of us dream exclusively in black and white. Most of us are older, who likely recall the days of black and white TV. Isn't the brain an amazing thing in terms of what it does? Just fascinating. Okay, let's talk about the anatomy of the nose. This is basic anatomy 101, the external and internal. Here's external. Nasal vestibule, that's what you typically would call the nares or the opening of the nose. That's this area here. And then the structure around the side of the nose here on either side is called the alar rim, also referred to as the external nasal valve. And this bridge in between is called the columella. Internally, we see the turbinates, and mostly what you see by looking in through the nasal vestibule here is going to be the inferior turbinate. You have to have a nasal speculum to be able to look in and see the middle turbinate, and you can't see with a speculum the superior turbinate. We know there's a nasal septum, which is behind the columella, okay? And we know that there's what's called choanae, anterior and posterior. And I'll show you that in a different cartoon, but the choanae is basically what walls off the nose and the anterior and the posterior. Remember I said we've got the nose to a certain point, and beyond that it's the nasal pharynx, and that's walled off by the posterior choanae. We have the nasal valve here, the gray area, which is basically not an anatomical area. It's basically a area in general that's walled off by the inferior turbinate or by the turbinates and by the nasal septum. And then the retropalatal area, which is the nasal pharynx, which is further back behind the posterior choanae. So here's what we're looking at in a CT scan. Here we see we see the turbinates, superior, middle, and then, I'm sorry, inferior, middle, and superior. This is the nasal septum. You see it's buckled a little bit. Here you see the nasal valve here. There's no nasal valve on this side, and the maxillary sinus here. Here's the eye socket here. Okay, so this is what we see if you were imaging it. And you can see some of this on a conventional panoramic X-ray. Okay, so here we see it again. Now we're looking at it through an endoscope. So here we see the turbinate. This is the septum. This is our nasal valve here. Looking at an X-ray, here we see a fairly decent amount of nasal valve with septal deviation. I call your attention to the middle turbinate here, which has this large air vacuole in it, large air cell in it. This is called a concha villosa. It's not pathologic. It's merely an air cell that has enlarged the middle turbinate, which, as you can see, was the source of buckling the septum. Here we see the same thing, only with now the turbinates have become hypertrophied, and you can see how they've walled off the nasal valve on each side. This would turn this patient immediately into an oral breather. This is a condition we most often see in children and adolescents, but can be seen in adults as well. This is called adenoidal facies. And it's called adenoidal facies because what we see here are the deadpan stare, the imbalance or the asymmetry of the eyes. We see the dark circles under the eyes on either side. These are called allergic shiners. We'll talk about those. The nose is small and flattened. The nasal vestibules are small. The lips are not sealing. There may be cracking or fissuring at the corners of the lips. And this is a typical pattern, again, called adenoidal facies, which is typical or pathognomonic of someone who's a mouth breather who cannot breathe adequately through the nose. Adenoidal facies, this was discussed in a monograph on nasal respiratory function and craniofacial growth in 1979, published by the University of Michigan. The adenoidal facies typically has a long history of mouth breathing. They have an open mouth posture, nose that appears flattened, nostrils are small and poorly developed, a short upper lip, I love this phrase, pouting lower lip, and a vacant facial expression. And these kids are just really, really well defined, and you can see them in our population. So here we see the allergic shiners. We see again the small nasal vestibules, the flattened nose, and we see the turbinates. Well, why do we have why do we have allergic shiners? Well, a lot of that has to do with venous stasis in the pterygoid plexus of veins at the posterior aspect of the nasal passages. I mentioned the choanine. Here's the anterior choanine, which is a rim of connective tissue here, fibrous tissue. And here's the posterior choanine, walling off the nose to the nasopharynx. So what happens is when the venous blood is pooling back in the pterygoid plexus of veins, we get a venous stasis that occurs. This, along with edema, becomes somewhat profuse and infiltrates the lower border of the eye, and hence the allergic shiner. Now, the nose does not have a conventional lymphatic system. So what happens is that the venous blood flow is its lymphatic system, and so the venous blood will pool, thinking that it's trying to draw something out of the nose when there's a lack of nasal breathing that's occurring. Function of the nasal turbinates, the inferior one is the largest one. It's roughly as long as your index finger. It's for airflow direction. It filters the air, but it also humidifies and heats the air. The middle turbinate protects the opening of the maxillary and ethmoidal sinuses. It's designed to buffer and protect the sinuses and pressurized airflow like CPAP. It also has a little bit of potential to do some humidification and heating of the air. And the superior turbinate protects the olfactory bulb. It's located superiorly up there, so it protects it from any injury. When you want to visualize the turbinates, the best way to do it is with the nasal speculum. So this is showing you in cartoon fashion the normal look of normal appearance of the nasal area with the inferior turbinate and the septum over here. Here you see moderately enlarged inferior turbinate, severely, and this is very obstructive. So this is what you would typically see if you were doing a nasal speculum evaluation. This is a type of speculum that I often recommend using. It's a disposable speculum. It's available from a company in Toledo, Ohio called Bionix. I'm sure you can probably find them in Canada as well. The main thing is you always want to go vertically. Do not go horizontally. If you use that speculum across the nasal vestibule, you're going to compress the turbinate, you're going to compress the septum, and you're going to get punched because that's going to hurt. So you always want to go vertically. Now, there's another way to do it. I want to show you by using this flashlight. This is a very bright flashlight. You can't use really your headlamps to do this or the overhead light. You need a bright light source that can go right up to this nostril. So here, once again, is the cartoon that indicates the anatomy. So what you do is you lift the tip of the nose gently, opening the nasal vestibule, and you shine this bright light into the nasal airway. And so by shining it in there, you can see fairly well what the nasal valve looks like, the enlargement, if there is any, of the inferior turbinates. You can point out or pick out if there's any kind of septal deviation to any degree. It at least gives you a ballpark look at what's going on within the nose by just simply lifting that tip of the nose with a finger or thumb. Now, there's a thing called nasal functional testing. And nasal functional testing is very important to do because this helps us to understand what might be going on. The first thing we want to look for is alar rim collapse. That's what we're seeing here. When the patient takes in a deep breath and the alar rim or the external nasal valve collapses in like this, that's what's happening during the nighttime when there's forced inspiration. They're collapsing the alar rims, they're causing the nasal valve to become minimal, and that's going to restrict airflow. Going to turn them into a mouth breather. Now, if this is happening, we do alar rim stabilization. We stabilize it with a Q-tip or a nasal swab or a cotton swab. You put that into the nostril here, just gently up into the nostril, and you have them do the same thing. Now this will still go in a little bit, still collapse a bit, but not nearly as much. And they'll go, wow, now I can breathe. That would indicate that something that's going to give them some nasal dilation is going to be helpful. We'll talk about that. You want to do the Cottle test then, impact of nasal dilation. This shows the Cottle test where the fingers are placed at the corner of the nose or the alar rims, and you gently pull out. And what that does is it pulls the inferior turbinate away from that nasal valve and opens the nasal valve just a small amount, which can have a significant impact upon respiration through the nose. And then we do a procedure where, like I showed in the last picture, we lift the tip of the nose with a finger and see if they can breathe any better. If they can, that can sometimes be an indication that the patient has a deviated septum. Now, the amount of opening of the nasal valve by doing the Cottle test or Cottle maneuver is very minimal, as I indicated. And this is based upon Pouet's law of flow dynamics. And what this law basically says is that for every amount a tube is opened or closed, flow is impacted to the fourth power. So flow dynamics says that if we just simply open it a small amount, the flow is going to increase or have a magnitude to the fourth power of opening. This is why just a little bit of opening of the nasal airway with some device or some maybe surgery or whatever is going to have a major impact. That's why the Cottle maneuver, you don't pull very hard, just gently. And this is why oral appliances can be beneficial with very minimal repositioning. Well, how does nasal airway impact sleep disordered breathing? Well, increased nasal airway resistance leads to increased inspiratory pressure or increased inspiratory drive. Increased endothoracic pressure then begins to occur, and that's a negative pressure, what's called a critical closing pressure. That leads to airway collapse and can then lead to snoring and sleep apnea. The nose and sleep disordered breathing, we know from the journal Chest back almost 20 years ago that sleep disordered breathing can result from or be made worse by nasal obstruction. Now, the reciprocal is not true. Just because you correct the nasal obstruction does not mean you're going to get rid of the potential for a sleep breathing disorder, but it can certainly be a contributing factor to improving it. Nasal breathing increases ventilatory drive. So if the air can go through easily, ventilatory drive is going to go down. Nasal occlusion, any cause, decreases nasal opening in normal subjects or patency. Nasal congestion, any cause predisposes to sleep disordered breathing. And oral breathing in children, as I pointed out before, with the studies by Woodside and Linder Aronson and so forth, leads to facial structural abnormalities. And the problem is that if we don't get to these abnormalities ahead of time, they're going to go on and on and on. Chronic rhinitis can also be a problem. With chronic rhinitis, nitric oxide production can typically go down a little bit. This is most frequently caused by allergy to pollen, seasonal allergies, house dust mites, and of course acid reflux that's associated with asthma. Well, as Yogi Berra said, it's tough to make predictions, especially about the future. You can't really predict whether or not anything is really going to be beneficial, but you would hope it will be. Well, where did this all begin? A little bit of history. You don't know, so I'm going to show you. In 1884, Clinton Wagner, who was an otorhinolaryngologist, published this little monograph, Habitual Breathing, Its Causes, Effects, and Treatment. And he quotes Shakespeare by saying, shut your mouth and stretch the nostrils wide. They were very aware of this over 100 years ago, that mouth breathing had some deleterious effects. In 1889, William Hill published in the British Medical Journal, and you can go online, by the way, and look this up. You can actually find the exact paper. And it's entitled On Some Causes of Backwardness and Stupidity in Children. We wouldn't get away with that today in our politically correct society. And the relief of these symptoms in some instances by nasopharyngeal saccharification. That means tonsillectomy, adenoidectomy. Can you imagine how crude it was back in 1889? In 1892, William Osler, who's considered to be the father of modern day medicine, documented sleep and daytime performance of children with sleep-related upper airway obstruction. He said the child is very stupid looking. At night, the child's sleep is greatly disturbed. Respirations are loud and snorting, and there are prolonged pauses followed by deep, noisy inspirations. The influence on mental development is striking, and it's possible to fix the attention for long at a time. He's basically describing ADHD. Persistent mouth breathing following adenoidectomy. This was published in the Boston Medical and Surgical Journal in 1913. Indicates how mouth breathing is not the norm. Examining the nose should be routine. Examine the nose for enlarged inferior turbinates, true hypertrophy, and for septal deviation. Do this before there is a high palate. If there is a high arch, you may need expansion. They were looking at this over 100 years ago. Even in today's world, most physicians, I dare say, are not really cognizant of the fact that the nasal airway differs from the oral airway. And that's a sad commentary. Then William Osler, again in 1919, noted chronic enlargement of the tissues of the tonsillar ring, that's Walderer's ring, affection of great importance and may influence in an extraordinary way the mental and body development of children. And he was writing about sleep problems at that time. So there's a lot of history that goes into this. Okay, here's another sidelight for you. This is Blue Lake and Nelson Lakes National Park in South Island, New Zealand, in the South Island. The visibility of this lake is world-renowned. It's 230 to 262 feet you can see down in this lake. It's still clear. The actual point where it becomes less clear, where looking through a body of water and it's no longer clear, is 280 feet. Thought you might want to know that. All right, how do we manage these problems? Well, nasal airway dilation or nasal cleansing helps. Olive oil, believe it or not, is helpful because it has a product in it called oleocanthal. And oleocanthal is a very potent anti-inflammatory. It's at the same level of a COX-2 inhibitor. Palatal expansion, mostly in children, although they show you some in adults. Allergy management or nasal sprays can be helpful. Mandibular repositioning helps, and it's been shown that just mandibular repositioning greatly improves nasal airway function. Surgery, nasal valve, aloe rim suspension, that can be helpful. Extra virgin olive oil, as I pointed out, dabbing a Q-tip in it, running it around the inside of the nose up about, 3/4 to an inch or so, sniffing it up gently. This can have a marked impact upon improved nasal breathing because of the anti-inflammatory properties. There is a product called Poneris, which was used by NASA to keep the astronauts, where it was so dry, their nasal passages open and reduce nasal congestion. This is available over the counter. It's very, very effective as an emollient. Using a nasal sinus rinse, this is a good one. Neomed sinus rinse can be very helpful. These little packets can be used in steam distilled water. Make sure it's steam distilled water because you don't want any impurities in the water. It's a combination of saline and sodium bicarbonate solutions. You can also use a neti pot, but this is preferable. And they make ones that are for adults and for children. As far as nasal dilation goes, this is my favorite device here. It's called Mute. It's from Australia, or at least that's where it was developed. It's got a little ratchet type thing here, so it can be expanded. So when the nasal vestibules are of different sizes, you can make one side a little bigger. It comes in 3 different sizes, small, medium, and large, and I do have a starter pack. You may be able to find these in your local pharmacy. If not, you can get them online. And of course, what can't you buy from Amazon? Other methods to consider: mouth taping. If nasal airway is open, use micropore tape or a similar device. Myofunctional therapy and exercises, particularly breathing exercises, can help. Maxillary expansion, rapid palatal expansion in children. You want to focus on growth and development. Weight can be a factor. I'll point that out. Manage any allergy that's there. And surgery if there's a structural or anatomical condition that may need to be addressed. This is micropore tape. You just place it over the lips gently. I have patients do it prior to going to bed, practice breathing through the nose before they actually go to sleep. They did come out with a device called Somnifix, which is a little shield that goes over the lips like this. So you can use one of those two. This can be very beneficial to retrain them to become nasal breathers. They don't use it full time. Myofunctional therapy or oral pharyngeal exercises. This is designed to get the tongue up into the palate, or what we call the spot. So the tip of the tongue is resting gently against the rugae. This creates a dam for mouth breathing, so air can't pass through. So even if there's a problem with lip seal, they still can't breathe through the mouth and forces them to be nasal breathers. This brings the tongue base out of the oral pharynx as well. And so now that whole area opens up. Remember, the tongue is a muscular hydrostat. The tongue functions like an elephant's trunk. You can bend it, twist it, move it in any direction. So if the tongue is laying low and is confined by the teeth in the lingual part, or the lingual part of the teeth in the oral cavity, and the tongue isn't up into the palate or up into the roof of the mouth where it belongs, base of tongue now occupies more of the oral pharyngeal airspace. So this is how oral pharyngeal exercises can be helpful. It's comprised of the tongue, that is comprised of 4 extrinsic muscles and 4 intrinsic muscles. They have external bony attachment, and the intrinsic terminate within the tongue mass. So this is a sort of a free-floating structure, if you will. Expansion, we can do rapid maxillary expansion, RP or RME. Schwartz appliance, which is removable for both maxilla and mandible. We can use sagittal appliances if we need AP changes, and the Clark twin block is very good for both lateral and AP changes as well. These are just some examples of cross-arch width expansion devices, a fixed RPE or the removable Schwartz expander, and you can see how it can help to facilitate arch width, create more of space in the maxilla. This is the Clark twin block, which can go laterally as well as AP. This is a product called Healthy Start out of Chicago, Illinois. This is a very good product from Orthotane, occlusal guide that can be used in children. They have a variety of devices that are used as the child ages. They're all removable devices, but they can create some very significant improvements. You can see before and afters just using these devices. I've used these for years, and I've had many, many children who have avoided fixed orthodontics in the process. Weight and inactivity with increasing BMI among adolescent patients. This leads to poor and fragmented sleep, and it's impacted by weight gain. The biggest impact is visceral or central obesity, or what you might refer to as the gut. May increase tendency to mouth breathe during the day and creates air hunger. So they tend to breathe harder. They want to get more air, but if they're breathing through the mouth, the quality of the air is not there, and they're not going to absorb the oxygen out of it. Common symptoms associated with this are ADD, ADHD, and sleep bruxism as well. Now, part of the reason why abdominal girth has an effect, or visceral obesity does, is because when the diaphragm is supposed to be pulling down during inspiration, it can't do that. So if there's abdominal girth here, it's pushing the diaphragm up, inhibiting the ability to get a true inspiratory pressure to inhale air. And so these people become shallow mouth breathers. As an aside, if you've paid any attention to now what's being called endotyping and phenotyping, and one of the big buzzwords with that is loop gain with oral appliance therapy, this all relates to it. And it's all related to what's happening with the shallow breathers that we may have created by virtue of mouth breathing and not nasally breathing. Manage allergy. There's a thing called the allergic march. And this is what happens in the individual in the first 3 years of life. Because first, from the birth to the to the third year, the tonsils and adenoids and that Waldemar's ring are our first line of defense. That's all lymphoidal tissue. So basically, what's happening is it's protecting us against allergies. But one of the cardinal signs that a child is about to develop allergy, according to the theories of the allergic march, is that they will have eczema in the first 3 years of life. And that's a cardinal sign that allergies are developing. There may be seasonal allergies. They can also be pet related, especially if pets are sleeping in the bedroom. Nasal sprays may be helpful for short term. Managing acid reflux. I always had patients do a trial of Prilosec OTC for 2 weeks and see if their nasal airway and their allergies improved. That could tell us that GERD was at play. Keep in mind that acid reflux or GERD has two types. It's got symptomatic and non-symptomatic. So not all patients will have symptoms. You can refer them to an allergist. That may improve if a tonsillectomy, adenoidectomy is done. And we have to consider a thing called overlap syndrome. And overlap syndrome means that we can have a sleep breathing disorder that is overlapping with asthma or overlapping with COPD in adults. So we have to be cognizant these things are overlapping to some degree. Surgical options involve tonsillectomy, adenoidectomy, or simply just adenoidectomy. We can do turbinate reductions and septoplasty if there's actually a physical anatomical problem. You can do allorim stabilization. There's a number of ways to do that, but you can also get that with the mute device. You can use breathe right strips as well, by the way, but they're a one-time use, whereas the mute device can be used multiple nights. You can do a columella reduction, especially when there's an excessive amount of tissue in the columella. There's what's called mini screw assisted RME or MARMI. And then MMA as an adult sometimes has to be the next step. Sorry. This is MARMI. This is an implanted, screwed in rapid palatal expansion device. And you can see the arch here to the arch here. And then the orthodontics is done, obviously, to bring the maxillary posterior teeth forward and close up this massive diastema that was done. That's the biggest challenge. But this is a process for adults now where they say maxillary expansion can't be done. Yes, it can. And what they show is look at what happens to the nasal valve. You see here it's 26 plus millimeters across, and here it's gone to 30.53, and the nasal valves are much bigger here than they were over here. So MARMI can be very effective. Developing relationships with our ENT physician colleagues, we have to go back and think about a thing called Costin syndrome. Now I'm really showing my age. Costin syndrome was one of the original definitions of temporomandibular disorders, because back in the 30s, Costin was an ENT at the University of Washington in St. Louis, Missouri. And patients would come in to see him because they had ear pain. And he would do an examination. He'd say, you don't have ear pain. You got a bite problem. Go see your dentist. Or you got a TMJ problem. Go see your dentist. And so originally, early on in the 30s, it was known as Costin syndrome, where they would have ear pain, but it was really more TMD. Well, that's what ENT physicians have some awareness of, that patients come in with ear problems or congestion or eustachian tube dysfunction, when in fact it could be a nasal airway problem. So refer patients for evaluation of nasal airway and upper airway if problems exist. consider ear-related issues, as I pointed out before with eustachian tubes, and it can be bidirectional in its relationship, especially if there are oral facial pain or TMD complaints. So this is the real McCoy here that I've given you tonight. And you're familiar with this phrase, yes? The real McCoy? Well, this is how it got started. This is William Bill McCoy. And he was called the real McCoy because in the southern part of Florida and the Keys, Bill McCoy back during Prohibition was a rum runner. And he was considered the real McCoy because he didn't try to cheat people. He was a very honest businessman who all he wanted was a fair dollar for the rum that he was bringing from the Caribbean into the United States during Prohibition. So if you've ever wondered where the phrase the real McCoy comes from, there's your source, William Bill McCoy. Well, what I've tried to do tonight is turn it up a degree. You know, at 212 degrees is the key. At 211 degrees, water's hot, but it doesn't boil. You kick it up a notch and water boils and steam is created. Well, steam will power a locomotive. That extra degree can define success. So to achieve success, we all need it to turn up a degree. And hopefully by better understanding of the importance of the nasal airway and how it plays into our everyday life and life of our patients and the importance of it for life in general, I hope tonight will spur you on to turn it up a degree to be more vigilant about nasal airway and nasal airway obstruction. Thank you for attending. I know it's getting late in Canada there, especially if you're in the eastern part. For me, it's 6 o'clock. So I'll stop here and David, entertain any questions that may be there.